Hi everybody, this is Dr. Ihab Abdurrahman Ihab Tarawa, consultant of acute care medicine at Soba University Hospital, professor of medicine, University of Khartoum. We are still doing our sessions, medication safety course, introduction to medication without harm. This session is about safe prescription. It will be split into two talks. Objectives of this session to discuss the importance of proper prescription and to discuss the process of rational prescribing. We go through define patient problem, specify therapeutic objectives, verify suitability of treatment, start treatment, and do the technical part of the prescription, give information to the patient by counseling, and monitor the effect of treatment. I remember that when I was graduated, when I was a young house officer, I remember that I was able to recall some of the medications, their formulary, their side effects, excretion, protein binding. But how to operate, how to prescribe and make the best selection was a big challenge to me. In my first week in the emergency room, I had a patient with severe malaria. The patient had already received chloroquine and without response, so he came with severe malaria, with confusion, high parasite count. And I have to write quinine. I know that quinine, it can cause hypertension, hypoglycemia, and it has cardiac toxicity. But how to write it, how to administer it, and what to monitor. Then I asked my senior house officer, and he asked me to write it in dextrose solution in fluid and give it over 4 hours. I wrote the prescription and I showed it to him, and he said it's okay. But then the family were so anxious. They have believed that quinine can induce renal failure. At that time, I'm not able to give them the information that malaria itself, when it is severe, the risk of renal failure can go up to 40 or even 60% in case of black water fever. But quinine itself, it is because when we give it to severe cases of malaria, and even the risk, if we give it in appropriate dose, in adjusted dose, in appropriate rate, the risk is very low. It doesn't exceed 10 to 15%. All these information are very important for me to manage the case and to give and counsel the patient and his family. Later on that day, the renal function came back and he has high creatinine. And then I asked the registrar, and he said we need to reduce the dose because of renal failure. Giving medication is a big challenge. Where do we stand? One study revealed that medical graduates choose an inappropriate or doubtful drug in about half of the cases. They write 1/3 of their prescription incorrectly, and in 2/3 of cases, they fail to give the patient important information about the medication, how to use it, what to monitor, and if there is any precautions. Some students think that they will improve their prescription skills after finishing medical school, but research shows that despite gain in general experience, prescribing skill do not improve much after graduation. Bad prescribing habit lead to ineffective and unsafe treatment, exacerbation or prolongation of illness, distress and harm to the patient, and higher cost of care. They also make the prescriber vulnerable. When you are not competent, then you will be vulnerable to influence which can cause irrational prescription, such as patient pressure, demand for prescribing certain drug, Sometimes you can imitate and your colleague, and also you can be exposed to pressure by drug representative and sale personnel. Later on, new graduate will copy the same, completing the cycle. So changing existing prescription habit is very difficult. Case study. This is a 52-year-old taxi driver complained of sore throat and cough, which started 2 weeks earlier with cold. He has stopped sneezing but still has a cough, especially at night. The patient is a heavy smoker who has often been advised to stop, but he's still smoking. Further history and examination reveal nothing special apart from a throat inflammation. The doctor again advised the patient to stop smoking and write a prescription of codeine tablet 50 milligram, one tab 3 times a day for 3 days. In this scenario, a patient with cough following cold, who is still a smoker, the provided might think a little bit and then give him the advice to stop smoking and give him a cough suppressant. It takes him a fraction of a second, but this is a very complicated process. We should define patient problem, specify therapeutic objectives, what do you want to achieve with treatment, verify the suitability of our treatment, is it safe and applicable to that patient, and then we start the treatment by writing the prescription in a way that fulfill all the criteria, and then to give patient appropriate information about this medication, and we have to monitor this patient. As you see in the diagram here, this is the iceberg of drug selection or medication selection. There are few stuff seen in the surface, but a lot of things are behind the water. Things that you can see on the surface, the approved indication and the brand name, formulary, bill, injection, dosage form, and the cost, whether it's covered by insurance or out of pocket, and basic efficacy data and the result of clinical trial. But many things are hidden under the surface, like drug-drug interaction, drug-food interaction, and pharmacogenetic of that patient, plus unapproved use. And if the clinical trial was biased, and whether it is industry funded or not, and even prescriber bias, they are also influenced by the market, hospital design, hospital formulary, and patient compliance. So prescribing is like an iceberg. Few stuff are seen in the surface and many things are hidden below the water. If we reflect back on this case, there are many options. One of them is to counsel this patient and give him advice about stop smoking. The second option, to give him some remedies like to inhale steam and some advice like treatment without drugs. The third advice is to give him a cough suppressant like codeine. And the fourth, if you are suspecting something serious, to refer him for more assessment or combination of these interventions. Case study. We will go through some scenarios. This is a 54-year-old man complained of severe sore throat, no general symptoms, no fever, slight redness of the throat, no other finding. The second patient, a woman who is 32-year, severe sore throat, and she has fever, she has chill, and significant symptom despite using penicillin for 1 week without improvement. The approach to this patient is to define their problem and then to design objectives, therapeutic objective and interventions. A patient usually presents with complaint or problem. It is obvious that making the right diagnosis is a crucial step in starting the correct treatment. To make the right diagnosis, it requires integration of many pieces of information. First, we focus on the patient complaint, we analyze it, we take detailed history, and then we examine and do appropriate lab tests, and sometimes we do radiological and other investigation. Sometimes we take a tissue diagnosis. Patient complaints are mostly linked to symptoms. A symptom is not a diagnosis, although it will usually lead to a diagnosis. So we have to do a thorough history and examination. And if we look back at these two scenarios, the first patient probably has a viral illness. He doesn't require any further testing. The second patient, it looks like a bacterial illness and is not responding to penicillin because there might be some resistance. So we need to do more review and then design appropriate interventions. As we mentioned, the first step is to define patient's problem, whether it's a disease or a disorder, whether it's sign of underlying disease, or the patient complaint reflecting some psychological or social problem or other problem. And it could be side effect of a medication, or the patient might come just asking for a refill, and is it appropriate or is it a polypharmacy? If the patient is adherent to treatment, and if the patient is requesting preventive treatment, and sometimes they come for combination of all these issues. After you define a patient problem, we have to specify our therapeutic objectives. Before choosing a treatment, it's essential to specify our therapeutic objectives. What do we want to achieve with this treatment? Specifying the therapeutic objectives is a good way to structure our thought and thinking. It forces us to concentrate on the real problem, which limit the number of treatment possibilities and so make our final decision much easier. This process of specifying therapeutic objectives will prevent a lot of unnecessary drug use. It is very important and it's a good idea to discuss the therapeutic objective with the patient before we start any treatment. This will empower our patient, it keep him engaged with treatment, and it also allows them to raise any concern or to highlight any problems that we have overlooked. Why making personal drug list? Globally, the number of approved drugs, they exceed 20,000. This is by FDA. WHO essential medication list, it includes more than 500 medicine. If we include all drug used now and under development and of limited use, we are talking about more than 100,000 different products. If we look at drug groups, in beta blocker we have more than 17 names. In angiotensin converting enzyme inhibitor, we are talking about 10 or more names: captopril, enalapril, lisinopril, benzapril, and so on. Imagine in your practice you are seeing 15, 20, or even up to 40 patients a day. Many of them, they need treatment. How do you manage to choose the right drug for each patient in a relatively short time? We have already spoke about the iceberg of prescribing. By using P-drug, personal drug, These drugs are the drug you have chosen to prescribe regularly and with which you have become familiar. They are your priority choice for given indication. If you look at yourself, you see that you prescribe certain drug more than others. Like for me, when I look in hypertension, usually I use X drug. For gastritis and reflux, I use that B drug. The personal drug concept is more than just the name or pharmacological substance. It also includes the dosage form, dosage schedule, and duration of treatment. The principle is universally valid. P-drug enable us to avoid repeated search for a good drug in daily practice, and as you see our P-drug regularly, we will get to know their side effect thoroughly with obvious benefit to the patient. When selecting a P drug, it's important to remember that we are choosing a drug of first choice to treat a common condition. For example, we are choosing amoxicillin for treating X disease or amlodipine for treating high blood pressure. So our goal, are we aiming for cure as in malaria and infectious disease, or for disease control as we treat diabetes and hypertension, or for symptom control in viral illnesses, or for palliation of symptom in degenerative diseases and advanced cancer? We are not choosing, when we are selecting a P drug, we are selecting a drug for a common disease. It is not for the individual patient. When we are treating a patient, then we need to make sure this medication is suitable for that patient. The process of selecting the P drug or the personal drug. If we look at medication, there are 10 of thousands of different drugs, but we only have around 70 pharmacological group like beta blocker, calcium channel blocker, antibiotics, and so on. When we are selecting, the first criteria is the efficacy, is the first criteria for selection. For example, if we are treating stable angina, we know that we can use beta blocker, calcium channel blocker, or the nitroglycerin. So we make inventory about effective group of drug linking their therapeutic objective. Initially, we should look at group of drug rather than individual drug, as the active substance in each drug group have the same working mechanism. Their effect, side effect, contraindication, and interaction are almost similar. For example, benzodiazepine, they have this spectrum of efficacy and side effects. The same applied for beta blocker, for a penicillin group of antibiotics. Efficacy is assessed by assessing data on pharmacodynamics and pharmacokinetics. In order to be effective, the drug has to reach a minimum plasma concentration, and the kinetic profile of the drug must allow for this with an easy dosage schedule. Kinetics should be compared on the ground of absorption, distribution, metabolism, and excretion, and we need to look at the result from the randomized control trial about the effect of this drug on individual in specific disease. Safety is assessed by assessing possible side effect and toxic effects. If possible, the incidence of frequent side effect and safety margin should be listed. Almost all side effects are directly linked to the working mechanism of the drug, with the exception of allergic reaction. For example, beta blocker, as they control tachycardia, they can lead to significant bradycardia. The third criteria is suitability. Although the final check will only be made with individual patients, some general aspect of suitability can be considered when selecting the P drug. For example, um, some medication like verapamil as a calcium channel blocker should be avoided in patients with significant bradycardia. Beta blocker should be avoided in patients with asthma. Contraindications are related to patient conditions such as other illness, which make it impossible to use P drug that is otherwise effective and safe. Also, change in the physiology of the patient can influence the dynamic and kinetic of a drug. So sometimes we need to adjust the drug according to the renal function and liver function or presence of other illnesses. Pregnancy and lactation, we have to check about the safety during pregnancy and dosage adjustment, plus the toxicity for the baby, whether the drug go through the placenta or excreted in milk. A convenient dosage form is very important. It allows patient compliance with the medication. After we look after efficacy, safety, suitability, we have to consider the cost. The cost of medication is very important. In countries where they have insurance, you have to make sure the medication is covered by insurance. Some insurance, they have preferred brand, and you have to make sure the patient gets the right brand. And some new products are very expensive, and there is no data to show that they are more effective than the old brand, and this should be looked at. And we have to look at the total cost of treatment. If a patient taking a treatment for a whole month or for his life, we need to look at that and to factor it in our assessment. The last thing is the combination. Combination is a very good way to give medication as it improves the compliance by reducing the number of pills, but sometimes combined pills are very expensive. So we have to discuss this with the patient and know his perspective. We will stop here and we'll continue the session in another lecture.